Welcome to COVID-19 and diagnostic testing, nurses on the front line. This is the second in a series of 3 webinars devoted to nursing education around COVID-19. This webinar is focused on nurses caring for patients in underserved communities. I'd like to acknowledge the financial support of Abbott to provide this nursing education around COVID-19. I'd also like to acknowledge that this information is current as of July 21st. We recognize that additional knowledge, information, and updates will continue to emerge as we battle this pandemic. The presenters for this webinar are Ms. Donna Thompson, Chief Executive Officer for the Access Community Health Network in Chicago, Illinois. An old colleague and friend of mine and a wonderful leader. And myself, Ann Scott-Bluen, President of PSQ Advisory. This webinar will cover an overview of the federally qualified health centers, FQHCs, and the population served across the United States. The special challenges of these high-risk populations will be discussed by Donna, focusing on populations at risk in the Black, African American, and Latinx communities. Social determinants of health presenting even more complex care needs will be addressed as Donna explains Access's integrated care model. Nurses' role in care coordination, community outreach, and testing as a part of this integrated care team will also be described. And then I'll describe some final thoughts about what nurses can do in today's environment around the pandemic. Donna, please, let me turn it to you. Thank you.
Thank you so much, Ann. It is a pleasure to reconnect. You know, I've never been so proud of nursing and being a nurse, especially during this unprecedented time. And to really speak about and recognize the various roles nursing has, especially through this pandemic. It really has been a strong call to arms. I'm proud today that over the last 25 years of my career, I've spent working in a federally qualified health center where it's really the nation's foundation of taking care of 28 million patients nationally who are underserved, many from minority and low-income communities. You know, in fact, the roots of community health centers really started in the 60s during President Lyndon Johnson's time of the Office of Equal Opportunity, where there was really a focus on how we can address the rates of poverty and its effect on low-income communities. You know, the first community health centers were born, one in Mississippi and the other one in Boston, in public housing and in rural Mississippi, where addressing issues like immunizations, making sure pregnant women got care on time, and really starting to address issues that we see, unfortunately, are plaguing many communities of color today, whether it be management of diabetes or asthma, or even making sure that there's a healthcare home. The exciting thing about community health centers is that they have a strong federal oversight. And as being a community health center, they really come in all different shapes and sizes, anywhere from those that are community health centers to lookalikes to those that are serving the homeless or migrant workers, or even those that are embedded in other public domains like county health departments. Some of the unique characteristics of community health centers, it really is about the voice of the community. They're community-based, patient majority board of directors with a focus not just on a medical-only model, but other enabling services, anywhere from dentistry to podiatry to also areas like legal services. And as we talk even further on about social determinants of health, community health centers had that part of their DNA starting back in the 60s. No one's ever turned away because of payer status. They're not free health clinics, but based on federal poverty guidelines, anyone who's uninsured can come in and get seen at a very nominal fee. And also, many of the programs tailored and embedded within community health centers are really focused on local community need. Some of the other highlights is that many community health centers get additional grant funding to really help support key programs like HIV care or high-risk maternal care, and even for those that are uninsured, as well as being eligible for the Federal Tort Claims Act, medical malpractice, and 340B program access. Now, the interesting place that I've been able to serve as a CEO for the last 15 years, Access Community Health Network. We're the proud community health network that serves mostly a Hispanic or Latinx and African American population in the Chicagoland area, where we're in Cook and DuPage County, proudly serving over 175,000 patients every year. But we also are in the 16 of the 20th most underserved communities in Chicago, as well as 89% of our patients are at or below 200% of poverty guidelines, meaning that, as we know, for many low-income communities where you might have a job today and lose that job tomorrow or have to go back on Medicaid, we're that consistent health care home regardless of your payer status. One of the other things that I want to point out, and this is just a glimpse of the life expectancy in Chicago, and this pandemic has really shed a light on. If you look in the red section where communities like Inglewood or Auburn Gresham, and compare that to other parts of Chicago, communities like Lincoln Square or North Park, there's a 5 to 10 year life expectancy difference where you live. And it shouldn't be where your real estate really defines your life expectancy. But these are some of the areas that low income, underserved, mostly community of color are plagued. It also magnifies that once something happens like this pandemic, where we're talking about years of not only healthcare disparities, but also issues of bias and racism. It has really put people in Chicago, for example, living in two worlds. One of the things I want to highlight is that many of our patients have complex healthcare needs. And what does this mean? Well, for many of those who are dealing with chronic care issues like diabetes or heart disease, but also behavioral health disorders, as well as issues around diabetes that can lead to obesity because not being clinically managed, as well as childhood conditions. These are all the underpinnings that, when we think about the effect of the pandemic has, and why we see so many untoward health outcomes.
Hey, Donna, could you address Access? I know has done a lot of work with your patients and their families around education on how to prevent getting COVID, but also how to prevent the spread and disseminate that realistically, given the family and living situations. Could you spend a moment just talking about that?
Absolutely, Ann, and that's a great question. You know, as nurses, our role of educating families and really understanding how this virus can have untoward outcomes, you know, making sure families understand the value of staying at home, understanding how to monitor their symptoms, understanding the need to be able to stay well hydrated, to get into their healthcare provider if they have symptoms, and also for those essential visits, because we don't want chronic illness to really be a driver disproportionately to affect them as they're trying to prevent COVID spread. But also understanding the value of washing their hands, making sure that if they have to self-isolate and not share personal items, and how to clean and disinfect frequently. These are all great tips on when we educate. But one of the areas as we look at some of the complexities of our patients is also understanding their lives. Patient education is integral, but it also means that we have to make sure that we're giving information that can be readily received, and also understanding some of the cultural nuances and issues that serve as barriers to our patients that might not be easily focused on or even seen. Issues around food insecurity, issues around literacy and really understanding the information, making sure that the information is given in a written format and in a language and a level that the receiver can comprehend. You know, when I think about addressing COVID in low-income communities, I often think about some of the invisible barriers. Issues of immigration and documentation status might prevent someone from readily coming to their provider or seeking care early on. Also, issues around intergenerational housing or even homelessness. Many times when we say homelessness, we don't think also about that teenager who might be 17 or 18 that might couch surf between their mom's house, their grandma's house, and maybe an auntie's house. Also, for many of our community residents, they are the essential workers. They are the ones going out on the front line every day. The ability to work remote is not an option. Also, high reliance on public transportation. And again, for those who every day have to go in as an essential worker, whether they're a store clerk or they work in a facilities department, you know, in housekeeping or being a cashier. These are all roles that they consistently come in contact either with the public or with areas where there's a high likelihood of contracting the virus. And so it's right. And so it's really important to really understand what these barriers are and to really pace your conversation with patients and families on understanding that these might be some barriers. You know,
It adds a level of complexity, doesn't it, to the
ab-
nurse's role?
Absolutely. And, you know, we can't talk about COVID, we can't talk about health and prevention unless we equally talk about these social and economic factors that drive health outcomes, whether it's food insecurity, you know, where you live, work, play, worship does have an impact on your health outcome.
Well, and it brings up the density factor that we've talked about, that, you know, people who live in multi-generational homes with access to a shared bathroom for 12 people have difficulty quarantining. So
Absolutely. And
okay.
that's where, to me, how nurses are the best at critical thinking, working with patients to help them think through options. And sometimes they might not be the best option, but they're a better option than what maybe the patient or family has even thought about.
Great.
And
Thanks, Donna.
absolutely. And again, one of the things that we have to look at, as so many of us might be thinking, oh my gosh, the pandemic, what might be top of mind for a family is making sure they stay employed, making sure they don't lose their housing, making sure that they can put food on the table. And so again, we have to keep all of this in mind. As we think about Chicago as an example, I'm putting up a slide that shows that people of color are disproportionately affected by COVID. You know, in Chicago alone, the Latinx population is nearly 4 times more likely to contract COVID-19 than their white counterparts. However, for Black residents, representing more than 2 times the number of COVID cases. But the next slide really shows that Black residents, unfortunately, are the ones that many times have the least of the worst outcome.
Can you talk a little bit, you've mentioned the Black residents, they're dying, unfortunately, at a significantly higher rate. They're disproportionately impacted, as you said, as are other people of color. Can you talk a little bit about how Access and you as the CEO have worked with other community partners, such as the Chicago Department of Health and the state of Illinois, to try to coordinate both testing and also diagnostic and other therapeutic services, really, for the patients that Access serves?
Great, Ann, and so timely. Access has been honored that we were part of really 36 healthcare organizations that really ran the gamut of not only public health department in Chicago, but also health systems, other community health centers, as well as community-based organizations. And the city of Chicago put together a racial equity rapid response team to address the disproportionate impact of COVID-19 on communities of color. You know, Black and brown people in Chicago, like many other cities, have been disproportionately affected by the virus at much larger rates. And I'm happy to say that one of the things that, as we've gotten together, including academics and researchers, to really look not only up the science, but the hot spots, but also to share our learnings in a collaborative way. And being able to also, with this alignment, to be able to even look even beyond COVID and talk about what should be different because of this experience. We're happy to say that Access was part of an op-ed in which there was a declaration from all 36 organizations addressing racial equity, racial bias, and ways that as our own institutions, we are going to collectively and individually begin to even address some of the long-standing issues that have served as barriers to people of color.
You know, that's fascinating. And I think it raises the fact that Access is embedded inside of the communities that you serve. So understanding those communities effectively and working with the city of Chicago and Cook County Department of Health and the state of Illinois is critical, as people from maybe outside those regions don't experience the same situation as people that are actually having that lived experience. Going back to your point, actually, that we have to listen as much as we have to talk when we're talking with patients and their families in underserved communities.
Absolutely. And, you know, and one of the areas that community health centers serve is that for many of our patients, as you described, there's so many areas where they don't have predictability, whether it's jobs or housing, even for many of our families that might get caught up in social justice or have a fear of immigration issues. But one of the things that we have always have focused on in many community health centers is how do you have a really integrative approach to care?
Can you talk about that a little bit more? Talk about your model, because I think it is
absolutely
maybe a little unique. Maybe there are other FQHCs out there doing it, but I think the way you've approached it is really creative and tries to get at the fact that healthcare occurs, or medical care occurs, within a larger context of people's lives. It's it's not the only thing that people are worried about. And
absolutely. Absolutely. Well, you know, the slide I'm showing now really shows our integrative approach to care. When we look at each of the petals, the patient is in the center. and along with coordination. Many times the coordinators are nurses, making sure that, every time that they engage the patient, one of the petals might take center stage over the others. Um, we know that constant engagement is key during this time of the pandemic, where we've had to rapidly go from face to face to telehealth. It was important for us to aggressively reach out and really make sure that we stayed connected to our patients. We're also using a model of shared decision making. That really is a way of putting more power into the hands of the patient. This evidence-based approach where information is given to the patient and then choices are made based on patient preference and support by the clinician and the clinical team. One of the other petals that we also have to equally focus on is behavioral health needs of our patients. During this pandemic, it's quite interesting how we've seen higher rates of opiate overdosing. But we've also understand that for many of our patients, just the pandemic itself has created more fears and concerns over with issues that patients, many of our patients' communities address daily. Being able to understand how to readily address this through our expert program, which again makes it possible for us to quickly do brief interventions and referral for treatments for those that are suffering from addictions, to using depression screening tools to quickly identify and support our patients along with their providers in quickly putting a plan together to address the depression. When we also think about the other petals, whether it's population health and understanding the acute and chronic needs of our patients, how to risk stratify so that we quickly get to those patients that have a higher risk of not doing well with COVID. I think about a lot of our patients who suffer from chronic illness. To earlier when we talked about social determinants of health, what's top of mind and service barriers. If a family is more worried about keeping their job, or if there's food insecurity or transportation needs, many times this is more top of mind than even the issues of what they need to do to protect themselves and their families from COVID. And then we are not a medical only model. Having other supportive services like dental co-located within our health centers, as well as pharmacy and other lab diagnostics, really give more of a robust one-stop approach for our patients and families. When I think about the nursing role and coordination of care, it's really exciting because so much of what we do now around prevention, it goes outside the traditional walls of a hospital or health system. The role of nursing during this time has to really be able to look at data, whether it's through the electronic health record, claims data, provider panels, pharmacy registries, and even how patients have ED and inpatient utilization to really identify those high-risk patients that we have to proactively reach out to. It's also about engagement and following up, whether it's notifying someone their test results if they've gone in for COVID testing, but then also having a conversation of who else they might have been in contact with that might also need to come in for testing. And then part of the engagement, whether it's telehealth or getting patients in for essential visits, is to really continue to address the education around monitoring for symptoms, regularly checking in with their provider, quarantining or self-isolating as needed, and again, making sure that those that they've been in contact with have come in to be tested for infection. It's important for nursing to also understand their role of engagement. whether it's through telehealth or face-to-face. It's important for our patients to understand that, and families to understand that they have to have an ongoing process to monitor for symptoms, quarantine or isolate, especially if they're COVID positive or if they've been exposed, and also where they can get tested for infection. Many times in our communities, being able to have a place readily available that they can get tested is something that we have to continue to advocate for, and to really make sure that people don't have to go for miles and miles to find an available place to test them for the infection. And even now, as healthcare providers, and we're knowing and understanding more about COVID and those that are symptomatic and non-symptomatic, even at Access, where we have expanded our testing to 5 sites, we've also opened it up for those whether they're symptomatic or non-symptomatic. And speaking of testing sites, it's important that we have aggressive community outreach. There's nothing like building a coalition of community organizations that can really advise us on really what will be the most effective way. It's also about having those trusted ambassadors who can also reach out and be a liaison between the healthcare community and the community at large, and to really make sure that we're meeting the needs of the community, not only by the way we educate, but also how we invite the community in to get tested and also allay their fears. One of the things that we have proactively done is, before we open any COVID site, to really have community meetings on our process, get their input, and also get advice on the best way that we can educate the community. We've had a lot of learnings through that, everything from our best process for social media to flyers, to also how can we use the community voice to encourage those to come in. I know recently we've partnered with gospel radio stations. We partnered with African American and Latinx radio stations and their radio personalities who have actually come in our sites to get COVID testing and put their experience on social media. Also, when we think about testing, one of the things that we really want to make sure is that we educate patients beforehand about what they can expect. Many organizations like ourselves will do a prior telehealth visit. One, we really want to find out if there has been other chronic issues, care needs, including behavioral health support that's needed. Also, if patients or families are food insecure, or if there's issues around transportation, we want to also be that vehicle to let them know where resources are available in their community if they did not know it was available. And also, we're looking more and more at how we can not only engage patients around an understanding around COVID and prevention, but also if they have not been active in their healthcare needs, if they don't have a healthcare home, this is a great opportunity to get that engagement started and have them follow up with the healthcare provider.
Donna, maybe we could spend a moment, or you could spend a moment discussing really America's now facing 2 crises: the pandemic, COVID-19, and the crisis that occurs from some of the longstanding issues of racism and some of the policing actions in large urban cities like Chicago. How has this complicated the ability for Access to care for both its patients, but also the staff? Can you spend a moment talking about that?
Absolutely, Anne, and thanks for really bringing this topic to the forefront, because we are at the intersection of 2 pandemics. One, COVID-19, as you said, and the other is addressing the history of racism that have negatively affected African American and other communities of color. Healthcare, when we think about long history that we also have to confront around the challenges that the role of implicit bias has had within healthcare. Many times when I use the word trust, I don't use that word loosely because it really is the basis of trust that we have to begin the conversation of engagement and to really make sure that our patients feel like they can be authentic, that they can be accepted, and that they can really share and help guide their healthcare outcomes. When we think about what's happening into this country right now, when I also think about our health centers and many times over the last month, some of the civil unrest that we've had experienced, we've had to pivot very quickly and to really make sure that our patients and families knew where they could get their medications, that they knew that we were still in business, that they knew that they could continue to reach out to them because we were aggressively reaching out to really make sure their needs were being met. As we continue on this journey, I think it's really important that not only from a patient and community standpoint, but also within healthcare, we really readily address sometimes what those invisible walls are to really start bringing them down and bringing them through the forefront. You know, it's really going to be about advocating, and this isn't about leadership. This is everyone's role in when they see something that is really biased or a barrier to care, that we individually and collectively address it. Not going to be easy. And for some, they might not see what we're talking about through their lens, but it's going to be important that we raise the question because we'll be a healthier nation. As I said before, the 36 health systems that got together in Chicago and really said that racism is a public health crisis, and that we have to collectively and individually make sure that at all levels that we readily advocate and address the needed changes. And when we talk about it, it's from advocacy, it's from education, but it's also a focus and understanding that many times what might be top of mind for us as healthcare providers may not be top of mind for a patient. It's no secret that in many urban areas where there's issues of violence or issues of really ingrained poverty and the issues that go along with that, you know, housing instability. Or do you feel like you're in a safe neighborhood? Are you going to have food on the table? That becomes top of mind and might not take the center stage that the issue of COVID-19 has had for many others. But it's also about leveraging tools like shared decision making to promote active listening by the provider and the clinical team, and making sure that patients are given all information so that they can make choices and actively participate in their care needs, and feel in control. You know, as we face the reality, the intersection of these two crises, it's really going to be important that we encourage, assess, and motivate. And when I talk about encourage, it means that not only our patients, but also our healthcare providers and teams, you know, the caregivers are stressed, the patients and the communities are stressed. And we've got to be able to encourage and have venues where everyone is able to express their feelings and get the support they need. Also, we've got to be able, from a community and patient perspective, to have an ongoing process to assess their needs for things like groceries and housing and stable transportation, but even things like medication refills and referrals. It's not just enough to give a referral, but we've got to ask, do you have a way to get there? And also what's top of mind for many Americans right now is job security. And we've got to really be able to design design our care system that will not have someone make a choice of whether they're going to lose a day's pay or go in for that needed referral. It shouldn't be which one. It should be how can we design a system that will allow for both. And then motivate through education and outreach, through community partnerships, and again, the long journey of building trust. That will help to stop the spread, and also to really make sure that at the same time we address these long-standing issues.
Anna, thank you so much for the really wonderful insights and the way that you've framed a very tough job for our nurses who work in federally qualified health centers, and particularly the role of coordination of care within the larger context of people living their lives. It's an anxiety-producing time for both the staff, the nurses that you have working with you in Access, and the other staff, the social workers, the support staff, as well as the patients and their families that you're fortunate enough, or we're fortunate enough to have you serve. I wanted to just close this discussion by talking about what nurses can actually do. One of the things that webinar 3 will cover is the ability for nurses to care for themselves. Nurses have to take care of themselves so that they can care for their patients. But nurses also are the standard bearers. They have to role model behaviors that can reduce the likelihood of that infection, spreading the infection, preventing it to begin with, and then spreading it. So if nurses need to wear masks, they need to wash their hands. They need to socially distance whenever possible. They need to role model the things that we're asking our patients and our communities to do. It's everybody's job 24/7. Our neighbors are watching us, our families are watching us, our patients are watching us. I think you made a really important point to recognize that in many communities, the social conditions and the living conditions are more difficult. When there is intense density, people have to use public transportation to get to work. There is not the choice that people can sit in their home and work remotely. Certainly understanding how community health centers, and particularly I think the way that you've designed the access to testing and to care at Access Community Health Network, play a huge role. We often hear a lot about emergency departments and ICUs in the media. We don't hear as much about what the community health centers are doing. So I'm grateful that you've spent time educating us in that regard. And then I think advocating for free diagnostic testing and making sure that people, as you said, have access to testing so that they don't have to go 30 miles to find out whether or not they have COVID. And then importantly, as we start to look at antibodies for people who may have had it and hopefully will have some immunity related to those antibodies. And then obviously, educating everybody that we know. I know each of us are ambassadors for education for our families and our communities. When people spread misinformation, we try to correct that misinformation. So thank you so much for spending the time being able to help us understand the role of community health centers, specifically Access in Chicago, and how well you've done in trying to learn and participate with the community partners that you have in preventing, diagnosing, and stopping the spread. Thank you.
Thank you so much, Ann.